young athlete. Exertional syncope, a harsh systolic murmur. Most students hear that combination and immediately say HOCM, and they are right. But on the actual exam, that is not enough. The NBME wants you to explain the mechanism. Why does this murmur exist? Why does it change with position? That is what we are going to build today. Read the question carefully. A 22-year-old male athlete collapses during a basketball game. His father died of a heart problem at age 38. On exam, a harsh crescendo-decrescendo systolic murmur at the left lower sternal border, and it gets louder when he stands up from squatting. Take a moment. Before I walk through it, what is the answer and why? Let us extract the clues one at a time. First, young male athlete with exertional syncope. This combination has a short differential. A HOCM, long QT syndrome, arrhythmia, anomalous coronary, but a murmur narrows it immediately. Second, family history. Father died of a heart problem at 38. That is a premature cardiac death and a first-degree relative. That is the autosomal dominant inheritance pattern of HOCM, beta-myosin heavy chain mutations, sarcomere protein defects. Third, and this is the key clue, the murmur gets louder with standing. That single finding locks in the diagnosis, not just HOCM, but the specific mechanism. Let me explain why. In HOCM, the interventricular septum hypertrophies asymmetrically. It becomes disproportionately thick, sometimes twice as thick as the posterior wall. This asymmetric hypertrophy narrows the left ventricular outflow tract, the LVOT, which is the channel between the ventricular septum and the anterior mitral leaflet. Here is where it gets mechanistically interesting. During systole, blood is forced to accelerate through this narrowed passage. High velocity creates a localized drop in pressure, the Venturi effect. That pressure drop sucks the anterior leaflet of the mitral valve toward the outflow tract. This is called systolic anterior motion, or SAM. SAM does two things. It worsens the obstruction. The mitral leaflet itself now partially blocks the LVOT, and it creates mitral regurgitation because the leaflet is pulled away from its normal coaptation point. Crucially, this obstruction is dynamic. It is not a fixed anatomic problem like calcified aortic stenosis. The degree of obstruction depends entirely on the size of the left ventricle during systole. Smaller LV equals worse obstruction equals louder murmur. This is why maneuvers are everything for HOCM questions. They all come back to one variable, left ventricular size. When the patient stands up from squatting, venous return drops. Blood pools in the lower extremities. Preload decreases. The left ventricle has less volume. It becomes smaller. The LVOT narrows further. Obstruction worsens. SAM is more pronounced. Murmur gets louder. That is exactly what the stem describes. Valsalva strain phase works the same way. Increased interthoracic pressure cuts venous return. Preload drops. LV shrinks. Murmur louder. Going the other direction, squatting increases venous return, fills the LV, reduces obstruction, and the murmur softens. Passive leg raise does the same. Isometric hand grip increases systemic vascular resistance, which keeps the LV full during systole. Again, murmur softer. Memorize this contrast. Cole, HOCM gets louder with standing and Valsalva. Aortic stenosis gets softer. MVP gets louder with standing but clicks earlier. That trio is the highest yield maneuver comparison in cardiology on step 1. The answer is B. Dynamic obstruction of the left ventricular outflow tract due to systolic anterior motion of the mitral valve. Parse every word. Dynamic, not fixed. LEO ET, outflow tract, not the valve leaflets, SAM. Anterior mitral leaflet, not posterior. The NBME sometimes presents distractor answers that change one word. Dynamic becomes fixed, SAM becomes thick in leaflets. Know each word. Choice A is aortic stenosis, the most dangerous trap on this question. same crescendo, decrescendo quality, same systolic timing, same location. 3 findings kill it. First, fixed obstruction. Aortic stenosis is caused by calcified leaflets. The obstruction does not change with LV filling. When the patient stands, LV volume drops, but the stenotic valve does not get worse. Cardiac output drops, and the murmur actually gets softer, opposite of what we see here. Second, radiation. Aortic stenosis radiates to the bilateral carotid arteries. This murmur is at the left lower sternal border with no radiation specified. Third, age. Calcific aortic stenosis is a disease of patients over 60. A 22-year-old with this presentation is not aortic stenosis. Bicuspid aortic valve can cause AS earlier, but even then, not at 22 with exertional syncope and a family history of premature death. Choice C, pulmonic stenosis, right-sided murmur. The key rule for right-sided murmurs is Carvallo's sign. They increase with inspiration because inspiration increases right-sided venous return. Pulmonic stenosis does not increase with standing. The stem specifically says the murmur changes with standing, a positional, not respiratory, change. Wrong mechanism, wrong location. Choice D, mitral regurgitation. The murmur quality is wrong. MR is hollow systolic. It starts with S1 and runs straight through to S2 like a plateau. It does not have a crescendo-decrescendo shape. It radiates to the axilla. And it does not change significantly with positional maneuvers. The shape alone eliminates D. Nope. HOCM itself causes some mitral regurgitation due to sand pulling the leaflet out of position. But that MR is a consequence of the primary dynamic obstruction, which is what the question is asking about. Choice C, VSD. Also hollow systolic, also at the left sternal border, but 3 problems. The murmur shape is wrong. Hollow systolic, not crescendo-decrescendo. It does not change with standing or Valsalva. And a VSD is a congenital defect. It does not newly present as a murmur in a 22-year-old athlete who was previously asymptomatic. The stem implies this is a new or newly discovered problem. Let me show you how I actually approached this on exam day, not memorizing diagnoses, but following a decision tree. First question, does the murmur change with positional maneuvers? Yes. That immediately tells me the obstruction is dynamic, not fixed. I have already eliminated aortic stenosis and pulmonic stenosis, which are fixed. Second question, does it get louder with standing and Valsalva? Yes. That narrows it to 2 things, HOCM or mitral valve prolapse. Both worsen with decreased preload. Third question, what is the murmur shape? Crescendo, decrescendo. MVP produces a late systolic murmur with a click, not crescendo. Decrescendo throughout. HOCM is confirmed. Fourth, demographics. Young male athlete, family history of premature cardiac death, every piece fits. On the real exam, you should reach answer B within 30 seconds. The remaining time is to double check you are not falling for a distractor. The phrase dynamic LVOT obstruction should feel automatic. Take home, young athlete, exertional syncope, murmur louder with standing or Valsalva, HOCM until proven otherwise. The mechanism is systolic anterior motion causing dynamic LVOT obstruction. Every word of answer, B, is fair game. Treatment, beta blockers first line. They slow the heart rate, increase diastolic filling time, allow the ventricle to feel better, and reduce the dynamic obstruction. Calcium channel blockers, verapamil specifically, are second line. Absolutely avoid vasodilators, diuretics in excess, and nitroglycerin. They all drop preload, shrink the left ventricle, and can cause hemodynamic collapse. This is a classic step 2 trap. A HOCM patient presents to the ED with chest pain. The team gives nitroglycerin and the patient crashes. You need to know why? High-risk patients, those with syncope, massive hypertrophy, ventricular arrhythmias, or a family history of sudden death, get an implantable cardioverter, defibrillator. Refractory symptoms, surgical septal, myectomy, or alcohol ablation of the first septal perforator. That is question 1. Dynamic LVOT obstruction, SAM, beta blockers. If this helped you think through a mechanism rather than just recognize a diagnosis, that is exactly the goal. Subscribe for one question per day. Tomorrow, acute promyelocytic leukemia, the T to 15/17 translocation, and why the treatment is essentially a vitamin. See you there.